Okay, so my name is Katie Burke. I'm from Temple University, and today I am going to kick us off talking about the Temple University Inclusive Health Equity Collaborative. So with that said, I will go ahead and shift to our slide where I'll give a quick overview of what we're going to cover today. Our agenda for today is to start by introducing ourselves and getting to know a little bit about all of you. Then we'll share about the Inclusive Health Equity Collaborative as a whole, followed by project overviews where we do a deep dive into a few specific projects within our initiative. And we'll conclude with a breakout discussion where we have the opportunity to talk about how COVID-19 has presented opportunities for all of us to address emerging needs, as well as to work collaboratively, ideally providing feedback and information to influence our work, as well as sharing information with all of you as you return to the work that you do. So with that said, we'll set the stage by introducing our team. As I mentioned, my name is Katie. I'm an assistant research professor at Temple University in special education. I also serve as a senior research associate at the Institute on Disabilities. We're a university center on excellence in developmental disabilities. And with that said, I will turn it over next to Tay Halleck to introduce herself.
Hi all, thanks for joining us today. My name is Tay Halleck and I work closely with this team at Temple University, where I am the Health Equity Coordinator at the Institute on Disabilities. Next, I'll talk to you, Phil.
Hi, I'm Philip McCallion. I'm a professor and the director of the School of Social Work at Temple University. And I'm one of the collaborators in this project. And in terms of COVID silver linings, it's been really nice at times to work from home.
Thanks for sharing that. I forgot about that as well, Phil. Great. Lisa?
Hi, everybody. I'm Lisa Ferretti. I'm an assistant professor of research at the Temple University School of Social Work. I'm also the director of our continuing education programs and our strategic initiatives. And I'm really glad to be here today. I would have to say that my COVID silver lining was that I got a new puppy. Yes, I'm one of the people that got a pandemic puppy, and it has been like the greatest joy of the last 2 years for me.
Thanks, Lisa. Amber?
Hi, everyone. Thanks for joining. My name is Amber Davidson. I'm also at Temple University. I work as a research coordinator in the REACH lab. My COVID silver lining is probably sleeping in a little bit. So not having to do a commute to work, I got to sleep in, and I don't love waking up early. So.
Thanks. And we also have a graduate student here with us from Temple, Nicole. Nicole, would you introduce yourself?
Hi, everyone. My name is Nicole. My official name is Xuejing, but I go by Nicole. I'm a PhD candidate in Temple University. My role here is I just joined the team in the summer. So the COVID silver lining for me is same with Lisa. I got a COVID puppy. He just turned 1 year old. So the good thing is I can stay home and spend more time with him.
Thank you all so much. And so now that you've gotten to hear a little bit from each of us, we would love to get to know a bit more about who we have here with us in the room. So with that said, I'm going to ask the Morehouse team to launch the first poll, which is where participants will let us know what region you're coming from. Okay, I think we had everyone participate who's not a presenter. I'll share the results on the screen. Can everybody see that? Could someone give me a nod or a thumbs up if you can? Okay, so it looks like we're coming about halfway from the Northeast and halfway from the South, which makes sense. We've got our Morehouse crew probably, and then some people in a more similar location to all of us from Temple. So great, that's good to know. And our next question, if the Morehouse team could launch the poll for what role you are in. Great. Wow. Okay. I'm excited to share this one. Interesting. So everyone on the call today, other than the presenters, are public health professionals. That's certainly interesting for us because we're coming from a variety of fields. And I wouldn't say that any of us specifically would identify as public health exclusively. So I think this will be a great opportunity for us to explain how we're doing this interdisciplinary work and, in a way, how the pandemic has brought us together to do that. Okay, and last question to get to know each of you. We are going to ask for your COVID silver linings. These options are actually the most common responses we got recently when we asked this question to our advisory board, which we'll talk about in a moment.
I didn't realize it should include puppy adoption.
Yes, that's very true. I don't think anyone brought up pets last time we asked, but that's pretty close to being my highlight too. Since I didn't share mine earlier, I'll share it while everyone is answering. My bubble for that first 6 months, especially when we all needed to be in really tight bubbles, was with my brother and sister-in-law and two nephews and a niece who live down the street. And it's just such a special time that I'll always remember with them. So thank you for answering. Interestingly, we had all the same answer here. Everyone felt really good about working from home and flexible work arrangements. So, so that's good to know. And we can talk about maybe how that interplays with how you're doing work now, and maybe how you're even interacting with other organizations professionally related to this. Okay, so thank you for sharing a bit of information about yourself. We're here again today to talk about the Temple Inclusive Health Equity Collaborative. And our primary goal is we're funded by both the CDC through the Pennsylvania Department of Health on a COVID-19 health disparities grant. So the goal is to reduce COVID-19 related health disparities for underserved populations. And the focus here was on existing needs that have been highlighted or exacerbated by the COVID-19 pandemic. So the three areas of focus within our current project and under our collaborative are improving health communications with our populations of interest, reducing social isolation and loneliness, and increasing access to technology. So what are the populations that we're talking about? Specifically, we're talking about people with disabilities, including people experiencing mental health challenges, as well as people who are aging. And as you'll see from the graphic here, we're also particularly interested in looking at people who are experiencing intersections around those three experiences of disability, mental health challenges, and who are aging. So we'll talk a bit about how we're doing work with the focuses that I described, as well as with these populations of interest. So this visual provides an overview of our three main areas, as well as the primary projects happening within each of these. We're going to do a deep dive into a few of these projects in just a moment, and you'll get to hear from some of the other wonderful co-presenters here, and then have an opportunity to talk about your feedback on those projects, as well as your own experiences personally and professionally during the pandemic. But so first, the first line you see all the way to the left, the column, is on improving health communication. So we have three projects going on right now. Those are around messaging and media guidelines, so better understanding how we effectively communicate with people related to public health emergencies. I won't go into detail on the Personal Stories Photo Voice Project and safe health safety planning, health safety training, because you're going to hear from two of our presenters on that. We are also focused on reducing social isolation for people within our three populations of interest. And these are topics as well that you'll hear from Phil and Lisa on, related to their efforts, an intervention called Making the Connection on reducing social isolation and loneliness, combating loneliness through friendly visiting, and the power of dependable souls, or pods. And then lastly, we'll also highlight briefly some of our efforts around access to technology We don't have one of our leads from the Connect with Tech team here today, but they have already been tremendously productive with tablet and hotspot distribution for people within our populations of interest, as well as tech support and app development. One thing I'll mention here that I didn't say previously is we've been really focused not only looking at people who may be multiply marginalized because of being members of multiple underserved population areas, but also who may be experiencing homelessness or economic insecurity as well. So our Inclusive Health Equity Collaborative is something that came together rapidly as we all had to immediately react to the challenges brought on by the COVID-19 pandemic. We knew each other through some various efforts and overlapping interests and projects, but we pulled together as an effort to do this interdisciplinary work in order to impact outcomes for people more broadly. You'll see that at the center of our work is our statewide advisory board. I'm going to get to that in just a moment, talking more about what that's comprised of and what we do. But the idea is that our statewide advisory board is then providing guidance and input to each of the organizations that is part of the collaborative. I'll briefly highlight that's the Institute on Disabilities that I mentioned earlier that Tay and I are both a part of. That is, again, a university center on excellence in developmental disabilities for Pennsylvania, and we're centered at Temple University. The Center for Self-Determination, Self-Direction, and Self-Care, which is where Phil McCallion and Lisa Ferretti are coming to us from. The TU Collaborative on Community Inclusion. We don't have a representative here with us today on that, but they focus on mental health supports. Reach Lab, we have Amber here today to talk about some of the efforts coming out of Reach Lab, and Tech Owl at IOD, which Tay and I will be sharing a bit more about. So to briefly touch on the advisory board, we recently had our first meeting, and it's comprised of 9 community members, organization, and government representatives from our 3 populations of interest: disability, aging, and mental health communities. It's been important for us to focus this work on meeting the needs of people who have these experiences, and thus we're heavily reliant on people doing work in this vein, and particularly people who have lived experience with some of the challenges highlighted by the pandemic that we're talking about. The goal for the advisory board is that the advisory board will act as a community voice to provide input on program needs, activities, recruitment, and impact. For the duration of this 2-year project that we're currently engaged in, the advisory board will meet quarterly with ongoing communication and feedback happening throughout the year as well. So the first question we have, you've heard a little bit about how we kind of rapidly grouped together to do this interdisciplinary work in an innovative way. And we're curious, for those of you who are on the call today, how has COVID facilitated the development of unique collaborative opportunities in your research, practice, and advocacy? So please feel free, if you're comfortable, to unmute yourself and share, or alternately, please feel free to communicate in the chat.
So this is Mitchell Blunt from the National Center for Primary Care here at Morehead School of Medicine. I think one of the big things that it has, likewise to what you all have presented, is really helped us build those collaborations with other partners. So we've been forced to really engage in a different way and be able to communicate on many different projects that we probably wouldn't have not done so rapidly had not been for the pandemic. So I think it has really helped us to engage better with our partners and open the opportunity for more projects and to be very specific.
Thank you so much for sharing. Absolutely. I think in some ways it was, the impetus we all needed to get that push out the door to work together. Anyone else? Especially those of you within the public health sector, I'm curious, what other disciplines have you been working with that maybe you didn't in the past, or maybe have been enhanced as part of responding to the pandemic?
I don't want to monopolize the group, but I guess I'll jump in again. I think pre-pandemic, we were focused on a lot more research specifically on clinicians specifically, but during COVID, specifically in our research and policy division, we have focused a lot more on engaging people with disabilities. So we actually have 2 projects that we did just during the phase of the pandemic and continuing to do. So I think we're shifting some of our focus and our priorities because of the pandemic as well, and realizing the need for it.
Mm-hmm. Yeah, I would agree with that. I'm seeing it more in my work now than ever, especially with some of the funding opportunities that are coming out. That's often at the center as well. Thank you so much, Mitchell. I also see someone, Sherry shared in the chat. Sherry shared in the chat. That's a mouthful. Working with the NCRN project, our organization has partnered with schools in Mississippi and Georgia to disseminate resources for teachers, students, and parents. Excellent. So partnering with schools is a big one. And I see Marshawn, did you want to share?
Yes, hi everyone. My name is Marshawn Sheldon. I'm a student at Morehouse School of Medicine, but I'm also a project manager for the University of Pennsylvania Health System. One project that came out of Penn Medicine, our former director of strategic ops, did a project called Operationalizing Equity to kind of help mobilize a lot of the vaccination efforts in West Philadelphia. That also led to some cross-functional team development within a couple of our departments at Penn. They traditionally worked a little bit siloed, but that was a great collaboration with some of the nursing departments, our data departments, and some of our strategic leadership as well.
That's fantastic. Marshawn, I'm so glad you're on here now hearing about that West Philly connection. Absolutely. And so one thing you brought up that I think we're going to continue to hit on, especially when we get to those breakout rooms, you mentioned the idea that all these people came together to focus on vaccine distribution, which, as we know, of course, vaccines are highly relevant to a number of other diseases, but the vaccine distribution has been something highly specific to COVID-19. So I think a big question mark for all of us is now, how do we take this momentum and what we've learned from working together and apply it to both future public health emergencies like a COVID-19, as well as just in general public health needs?
Absolutely.
All right, thank you everyone so much. It was great to hear a little bit more from all of you.
Actually,
So with
Katie,
that,
Clarissa put in the chat expansion of food bank partnerships.
Oh, thank you. Wonderful. Yes, I missed that above there. Absolutely. 100%. Another, as I mentioned, kind of a need like food and housing insecurity is something that whenever possible, we've also been trying to focus our efforts on sort of some of those correlated needs. When we talk about health needs, food insecurity is something highly relevant, as is housing insecurity. Okay, thank you so much. All right, I believe I'm going to go ahead and turn it over to Amber.
Hi, everyone. Thanks again for joining us today. So my part of the project is called the SAFE Health Safety Training Program, and it's part of the health communication piece. And the reason the SAFE training program came about is because, like all of you, no one really had any idea what was happening in the beginning of all of this panic and COVID-19. So we really identified that if we were, very unsure, then our population that we work with in the REACH lab, which is individuals with intellectual and developmental disabilities, we were kind of assuming that they probably too were very confused with all of this messaging. So that's kind of how our SAFE program was created. We really wanted to identify how we could create a more accessible information and a more accessible curriculum for those who had intellectual or developmental disabilities to look at and be involved in. So in order to create that program, we really wanted to, it's very important to us, our lab is very much prioritized on involving people who have lived experiences and all different stakeholders as part of the conversation. So we involved our participants that had been parts of other projects with us, as well as researchers, different organizations, and community agencies. So the SAFE training program itself, once we involved all of those different groups, we had to identify what needed to go in here. Like, what was the important information that we needed to include? And so when working with different agencies in the community, we realized that oftentimes this population was still in essential roles in their community and needed to identify, what is actually happening? What is COVID-19? What are ways that we can properly use PPE? How do we social distance, community participation? What are the new challenges in employment? What does it look like now? And then most of all, like, how can we advocate for ourselves? How can we understand this idea of self-efficacy? So we piloted this program that we created. So we created a curriculum. We really thought we had come up with a really nice, accessible way. We tried to involve all sorts of learning styles, videos, hands-on experiences. Of course, most of this was done via Zoom. Not all of it, though. We did have some OTs that were occupational therapists that were out in the community and were involved and implementing the program like hands-on. But we wanted to really see, was our program, the intention that it was accessible, did we actually create something that was accessible? And we got some feedback. Some of the feedback was really positive. They really liked, our videos and some things that they worked with there. They liked some hands-on experiences. The advocacy piece, we weren't terrific at. There were people that definitely increased some of their ability to speak up for themselves, but oftentimes we weren't quite there yet. As far as our trainer feedback, so this was the support staffs, like job coaches and things like that in the community. We had gotten some positive reaction about their ability to build relationships and kind of engagement, but we also got some pretty constructive feedback that this accessible idea that we had is still not working. So we had not created materials that we really wanted to. It was still confusing and not exactly where it needed to be. So that led to where we currently are, which is basically trying to, again, identify how can we create this program so that it's very accessible, so that it gives across the proper information that we need to promote and disseminate. And in order to do that, we're back to the ground where we're asking these individuals who have lived experience to tell us what is their knowledge. Like, what do they already know? What do they know about preventative behaviors, training programs? What are their preferred learning styles? And how can they best learn with a new technique that we call peer support? We really think learning from people who are similar to you and have similar disabilities is a great way to actually learn a new skill or something new like COVID-19 knowledge. So in order to do that, like I said, we asked a bunch of individuals about all of those different things, and now we're looking at their responses. And when we look at their responses, we're trying to identify these areas that we can improve our SAFE program. We're looking for things that are consistent with the information that's out there already. We're also looking for, more importantly, things that aren't consistent and what we need to make sure we identify correctly. And then we're really trying to focus on this preferred learning style and how to best incorporate the curriculum. So our future goals over the next, I guess, year and a half now, or just about a year, is to continue to ask these questions, like how can we better create our SAFE program? So we do that with some more surveys, and then we kind of analyze what the results are. And then we make as many revisions as we see fit to our program. And then finally, we're going to implement our program. We have 3 different ways of doing that. The first is through researchers, support staff, and then we have occupational therapists that will be trained on this curriculum. And then our third way is through the peer interventionist, somebody with lived experience, similar age and similar disability. And that is it for our SAFE program.
Thank you so much, Amber. We appreciate that overview. Now we will turn it over to Phil and Lisa to share a bit more about their efforts as part of the Inclusive Health Equity Collaborative.
I think actually we'll start with a poll question.
So I think if the Morehouse facilitation team could launch that poll, there we go.
There we go. Okay, you'll see there's actually an interesting distribution. There were some people just a couple of days that they felt isolated, but others it was 4 or 5, actually the majority were 5 days out of 7. And so as we start this project, and we've talked about sort of providing the opportunity for people to tell their stories, I very deliberately asked the question about the first 18 months, because one of the challenges that we have as we move forward is understanding what people's experiences were throughout the entire period and what COVID represents as we move forward. So in terms of our piece of the project, we're really trying to understand how to better respond to the unique loneliness, isolation, depression, and anxiety challenges for older adults and people with disabilities. We're piloting some interventions. We're adjusting some interventions based on some of the surveying that we're doing. And we are manualizing and validating those interventions. And our intention would be to make those interventions then available as online trainings. Moving forward from that, we are really sort of moving into sort of gathering. I mean, we're well underway in terms of gathering information on what was experienced and in asking people themselves what was needed in response. There were interventions available. We want to understand the barriers that people experienced. We saw ourselves increasingly utilizing technology in the delivery of interventions, which was relatively new for the types of interventions that we've traditionally provided, and wanted to look at sort of what were the issues around readiness and making sure that while we want to be as inclusive as possible in community-based interventions, also that the unique issues related to aging, related to disability, were appropriately addressed. So within that, then I'm going to turn things over to Lisa to talk about some of the specific interventions we've been looking at.
Thanks a lot, Phil. So I'm going to talk to you about 2 interventions, one that actually the pilot work predated to some extent the pandemic, and the other one is one that's kind of been born out of what's been happening in the pandemic for older adults. The first intervention I'm going to talk to you about is something called Making a Connection. And actually, the original title for this program when it was piloted was called the Effective Connections Program. And honestly, some of the feedback we got was that people didn't like that too much. So the name got changed. But this was really born out of a community-based research project that we were actually working on in 2018 and 2019. And that work involved like a surveying of about 500 community members. It involved some presentations, some focus groups, and some in-depth interviews to try and really understand what these older adults were experiencing in terms of loneliness and isolation, and what factors they felt contributed to that, and what other things maybe helped them with that. All these folks were living in the community, either independently, or in senior housing, but they all had some sort of service connection, if you will. So they were connected to some kind of service that was helping them with case management, with health and wellness, and with their health care. There were 2 things that came out of that were really not shocking, but also we did need to pay a lot of attention to as we developed this intervention. And the 2 factors that people noted the most as being problematic were really being a caregiver, which we know is a very isolating experience for many people. And the other one was really these cumulative losses that people were experiencing, whether that was related to loss of a spouse, a partner, family members, and even friends, and also loss of some roles that people had as well. So those are the things that kind of came to the surface that we decided to sort of look at in this intervention. And the intervention itself was delivered to just a small number of people, about 28 folks. And again, we did see these trends in reductions in isolation. And from the feedback that we got, we sort of retooled this. But the real interesting thing about this intervention was that it was fully designed. We had about 100 people recruited to do these programs, and they all started in mid-March 2020. So none of them started. So the entire thing had to be kind of reworked. And so we had to go back to these kind of community researchers, our partners in the community, and try and rework this entire process. And not only was that about like technology, but it was also about, well, people are now experiencing this, either forced or self-isolation around the pandemic. And how is that impacting their experiences of loneliness and isolation already? And so that we had to think about, like, how do we do this in a way that kind of can address that and still get kind of at the heart of some of the other issues people were experiencing. So we retooled this. We delivered it on Zoom. That came with some challenges of its own. The technology piece people are going to talk about later, so I won't get into that in a big way here. But just, anecdotally, every week, there was a lot of work with folks around the technology and how to use it. And it did really help to sort of set up like our understanding of like what's really sort of needed before we do this, to make sure that if people are going to use technology, they can use it in a way that is friendly for them and where they can still feel kind of safe. And that's been a real big issue with older adult populations around some of these technology interventions, because we drill into people's heads, how unsafe the internet is and how unsafe all these things are. And then now we're turning around and saying, oh, no, we have to use this. This is how we're going to, help you with this problem. So if I could have the next slide. So we have retooled the intervention based on all that feedback and based on the experience that we had. We're now set up to do this in these small psychoeducational groups. We shortened the length of the group, but we also shortened out some of the content because we got a lot of feedback that people really wanted to spend more time, with one another, with a facilitator there just kind of helping to support them in their understanding and their experience. So we changed up a lot of the content, and now we're also going to be delivering this in 3 different ways. It'll be in person, as long as that's possible. We will still use the video conferencing platform because that works well for some people. And then the third thing that was suggested to us was to do this in an asynchronous format that's like a discussion board, if you will, so that folks don't have to be in the same place at the same time. And then other people, could potentially join, and it's a little bit more fluid. The program is, like Amber had mentioned, it's very much based on self-management, self-efficacy approach. Right. So we utilize group discussion and feedback and goal setting and other things to help people to develop the strategies and skills they need to find the support that they need. But also, one of the things people said was really important to us is to learn to be a better support to one another. There's a lot of kind of cognitive restructuring that happens. So we talk a lot about sort of people's thinking and, the narrative we tell ourselves that keeps us from trying to reach out, especially in these kind of maybe different or unique ways, or to develop these new skills. So we do a lot of work around that. And really, again, we focus in on developing skills that'll sort of last a lifetime. Some of those are skills around, the technology piece, which is what we really found in the programs we delivered during the pandemic. But some of it is also just around, how to find resources, how to make support systems work for you, how to navigate healthcare, all these kinds of things, all the way to like simple things that you can be doing at home that are also still going to be helpful to you in terms of your overall health and well-being, which may make it easier for you to kind of find the supports that you need and to reach out, which is obviously one of the things we know the most about social isolation, is that, finding people to be connected to is one of the most important things for folks in the midst of these issues. So next slide. We also are working to develop a sort of an intervention that's, again, the technology kind of intervention around what's called the friendly visitor program. So you've all probably heard of friendly visitor programs before. You may or may not have heard the Senior Companion Program. The Senior Companion Program is a program that is authorized by the Older Americans Act and runs through area agencies on aging throughout the United States. We are partnered with the Philadelphia Corporation on Aging Senior Companion Program, and we have about 30 members of that group who, up until the pandemic, were going into people's homes and visiting with people as a way to kind of help people with their social isolation and to keep them connected to their communities. And obviously, again, during COVID, that stopped. So there's both the effect it had on the people who were potentially at home, all of the time or most of the time. And it had a similar effect on the people who now couldn't go out to visit either. So they were sort of experiencing some of these same things. So we did some work with the Philadelphia Corporation on Aging to think about how they could stay connected. So in the short term, what they did was they started to do a like a phone visitor program, right? So they connected with people by phone. That was really successful, but it still kind of lacked the ability for some of the resources to be shared in the ways that they had been shared in the past. And so what we're at right now with this group of people is they've all just got new iPads, and we are working to train them both on how to use their own iPads for their own, work that they do, their volunteer work that they do as senior companions, and also how to use them for themselves in terms of connecting with other programs, people, family members, and whatnot. And then we're going to train them all on how to train the people that they visit with. So that's going to happen over the course of about the next 6 months. And what we're learning so far, we just did our intake process with all of this, is there's a lot of work to do here. And so I'm really glad we're going to talk about the Tech Health program next, because for most of these folks, the first questions we get are like, I don't even know how to turn this thing on, much less be able to use it for some of these other things, which I think really speaks to, I don't think necessarily just older adults, but people who just haven't used technology in this way before. They might be able to get away with a lot of things on their smartphone, but they're going to have their issues with something that's a little bit more advanced than that, in particular when it's about connecting with other people. And as I said before, the safety issue in technology is a huge issue for older adults. And so there's a lot of work around, helping people to understand how to use technology in a safe way through this connected program. So those are the things that we're working on. I don't think anybody's talking on the PODS program, so I think I'm going to turn it over to Tay now for a little bit more talk about tech.
Thank you, Lisa. Yeah, I think that this is a perfect segue into the last branch of our project activities, which are really focused on increasing access to technology, and not just access to the physical device, but the internet connection that links you to the World Wide Web, and the skills that digital literacy that you need to effectively use your technology in meaningful ways. So unfortunately, we don't have our Senior Director of Assistive Technology Programs with us today, Kim Singleton. I'm going to do my very best to represent the incredible work that she has done through this program and Tech OWL, which is our Assistive Technology Act program in Pennsylvania. So the goal of Connect with Tech is really, as I said, increasing access to technology as a way to increase access to health services and health information, and then providing the support needed to leverage that for really engaged use of the technology. A lot like some of the other programs that emerged during the pandemic, this started as a homegrown effort to get technology into folks' hands when they couldn't get out of their homes. Everyone was doing an informal collection of old devices that were sitting at home unused. Kim's team was wiping them, sending them out. It was really an informal response to an immediate need in the community. And it's been amazing to sort of see how it's grown into this statewide distribution program. And I think as the pandemic has progressed and we've seen the emergence of new needs, this new reliance on telehealth. It's been fascinating to hear, even in recent weeks and months, this recognition of broadband access as a social determinant of health. There are so many opportunities, I think, in future work in this area. And a key part of the work of Connect with Tech and Tech OWL is ensuring that people with disabilities are at the forefront of our planning for next steps. How do we make sure with this new adaptation of telehealth that those services are accessible? Because if they're not accessible, it's not really expanding services in a way that would be really innovative. So making sure that that innovation is centered on folks who would benefit from it and that they don't get left behind. So with our next slide, when we talk about the devices that we're sending out, it's not just the tablet, but we're including a case, a stylus, Headphones were a really big one. If you're not accessing your internet connection from home, having a set of headphones can really add a layer of privacy to that experience. And we are primarily distributing Samsungs, but I'll note that we also have some Lenovo's, which are a little bit bigger, and we're prioritizing those for folks who have low vision. I just updated the numbers on this for this week. Kim has done an incredible job of getting technology out. I think that they officially launched their application around Martin Luther King Day. So just in a few short months, they have processed almost 2,000 applications. Of those applications, 1,200 folks are eligible. I'll note for those that are ineligible, the main reason that people have been found ineligible for a tablet is that they, within the past year or so, have been a recipient of a device from our tech programs. But we have lots of folks getting those devices. Her team is working really hard on assembling, putting the stylus and the case and everything together and getting those out to the community. And then after people receive their devices, we have lots of folks receiving support, and we're keeping track of the type of support required. I think so far, the majority has been, getting set up. I think also Lisa mentioned this, some folks have to go through the process of learning, how do you turn on the tablet? How do you navigate on a flat screen, the swiping, the tapping? It's a whole new way of engaging with a piece of technology. And to support that, we have worked with Generations Online to develop some specific apps that work as tutorials to get people oriented to learning how to tap and how to swipe and how to use their device once they have it. Because it doesn't do any good if it sits on top of a stack of books next to the couch. We want people to be using their devices in meaningful ways. And meaningful is really varied. We have a focus on health equity and making sure that people can use their technology to access health services, telehealth, a variety of telehealth services. And, but also I'll point your attention to the blue staying in touchscreen. We also want people to use it in ways that are meaningful, sending an email to their family, being able to video chat. If you can't drive a couple hours to see your family upstate, you can at least have a video call. And that really helps with the social connection that we know has a huge impact on well-being. So that is another sort of big piece. We want people to be able to use their technology for health services, but also to promote that social network as well. You are more than welcome to drop that link into your own browser and check it out. It is really intended for use on a tablet, so that's one thing to be aware of. But these are, if you're interested in sort of checking out the tutorials that are in use for people who receive the tablets now, there are also some resources under development for our tech coaches who are providing that support. As Lisa mentioned, that safety awareness, we've created resources for our tech coaches to help talk folks through how to identify sort of accurate health information online. How do you tell if a website is a good source of information? We've seen that become a big issue with the pandemic. So being able to navigate that is important. So that is a very brief overview of our Connect with Tech program. Next, we really want to open up the floor for discussion. We have a small enough group. We had originally intended on doing breakout rooms, but as much as we want to hear from you, we also want you to hear from each other. I think that having an opportunity on a stage like this to really engage with folks who are doing different types of work in different regions and learning from the sort of creative strategies that you've come up with is one of the goals from the summit. So we have a couple discussion questions that we'd like to open up to hear from you about how your programs and organizations are really navigating the pandemic. And this theme of windows of opportunity. We called it silver linings. What are the things that are really invigorating the work that you're doing, and sort of what are the next steps? How do we navigate this and take a really bad situation and turn it into something that will have a lasting impact? So, Katie, I don't know if we have some big picture questions, but we also had some further prompts. I don't know if we maybe want to move through them one at a time.
That's what I was thinking. Maybe if we shoot to spend anywhere from kind of 5 to 10 minutes on each of these pages and see what discussion comes about. Certainly we can move on more quickly or spend more time if need to, but we would really love to hear from you here. So the first question we had was, what are the potential impacts of stressors and changes from COVID on our communities? We're talking about aging, mental health needs, and disabilities, but we would also love to hear you tie in more, thinking about the populations that you work with. And so how do we navigate those stressors and changes? I see Mitchell unmuting.
I'll jump in and get the discussion going. I just go back to even what I mentioned earlier about even our studies that we're doing, assessing especially assessing telehealth use with people with disabilities. And it's the stress of them having to actually afford or have the right technologies to be able to access their healthcare. It was hard enough to be able to find a provider that also has the technology to be able to actually conduct the appointment. So that's stressful, number one. And then with some providers now transitioning back to only in-person only is the transportation issue. So, we've heard in both of our studies that although telehealth and technologies are a great thing, the additional stressors of, okay, can I afford the technology? Do I have, they lack the digital literacy necessary to be able to engage with the provider? Does the provider have the right literacy? So all of those compounding on each other. And I love how you all are intersecting aging and mental health as well, because I haven't thought about that as much. What is our aging community? What are the stressors that they have? If the disabilities community has stressors, aging community does. So I think we really just have to take a deeper dive on both, and the work that you all are doing is really kind of great highlighting those things. So I think we all have to take that look, observation as well.
Mitchell, some of the data that's coming out really speaks to that people who are older, people with disabilities have not been participating in telehealth at the same levels as other groups. And also, as we're looking at, I'm not going to say we're out of COVID, but as COVID has changed over the last few months, people are also talking about there being a drop-off in the use of telehealth. And I'd be interested in your perspective on both those issues.
Yeah, so at least what we've been seeing, particularly in one of our studies, that people with disabilities, they actually are using telehealth, and they've been using it at a very robust and rapid rate. The flip side of that is that although they're using it and many are satisfied with it, there's still those barriers. So there's still the technology barrier, broadband and internet access. And again, that barrier of, well, will my insurance cover this visit? That, some of them, they have Medicaid or Medicare, but depending on the visit type and how the physician actually codes the visit, their insurance may not cover it. So I think we have to look at it on, again, those infrastructure, but also on the policy side. So how do we advocate for more robust policy for continuing Medicaid expansion, continuing allowing payment for telehealth visits, even post-pandemic?
Thank you. I wonder if anyone else has a perspective on this.
Well, this is Clarissa, and I'll jump in. I'm honored to serve as part of the CERSIM group there with Mitchell. And we also serve on the NOVA Geriatric Education Workforce Program. And so we have worked on this for a couple of years in regard to both aging and behavioral health. So they have some amazing HRSA consultants that have been in the field for years for our older populations, and proud to be a Floridian. And we do have quite a few of our elders here in our state, but we're working on making sure that our primary care providers are all trained specifically on the areas of older adults, dementia, all the things that go with that. And in particular with COVID, we're screening for isolation of older adults, looking at a broader perspective of behavioral health challenges that might be comorbidities, and then also screening for that early detection of dementia and the ever important social determinants of health due to COVID. And we have 52 federally qualified health centers as our members, with over 700 locations. And I will say, in regard to some silver lining with all of this, is our mobile units that we had for primary care and dental. Those were, taken out into the communities and partnered with the food insecurity banks that I talked about earlier, the housing situations, especially for first-time homelessness, to make sure that they understood the resources, and always having a behavioral health specialist or someone trained in mental health first aid just to screen and be there and refer as needed. So a little bit of aging, a little bit of behavioral health, but certainly telehealth has been big. It has started to wane, as you mentioned, but I think right now the federally qualified health centers are going through this whole lasting lessons learned from the pandemic. And so we'll be able to talk more about that later, but I just wanted to add that.
Thank you.
Yeah, thank you, Clarissa. I think, the discussion about telehealth also really puts in perspective for me all the connect with tech work that we talk about. We largely often frame that as just in a way the right to access to technology. It's become such a part of so many of our lives, and yet that access is not always the same for people with disabilities. But for me, that thought doesn't even always extend as far as also being access to healthcare, which more and more it now is. And so thinking about that as, in a way, an important, not necessarily prerequisite, but it can be a prerequisite. Thanks. And I see for anyone who didn't see it, Mitchell shared some results from their telehealth disability study in the chat, so you can take a look. In the interest of time, I'll move us on to our next set of questions. And I'm really curious to hear what you all have to share about this. So how have priorities related to COVID-19 efforts shifted for our communities, or what priorities have shifted? So especially thinking about those evolving needs throughout the pandemic, and then kind of what feels most pressing right now for all of you? What are those things that you're focused on immediately responding to?
I'll have a few comments. Good afternoon, everybody. Yeah, I think, I guess one story I can tell, I have a mother-in-law who's in she's actually one of the personal care homes. And we were able to pick her up because my wife has siblings, and she could go between the house the houses, but a lot of course, the residents weren't able to be picked up. But one thing we noticed by the time we went back, we went to a room, and this, I mean, this is not a nursing home. You know, a nice facility, but when we went back, some of her things were missing. And the staff had been cut, either from COVID or, you know, people left the jobs. And we kind of wondered what had occurred with those residents who had stayed, outside of just something being stolen, you know. Because we know as we tried to go back up there one time, they were kind of guarded. Of course, you had to have certain things, but when you went back in there, you know, you just saw that they were understaffed, and you just wondered what went on. And I say that to say this: there are a lot of things that's been happening during COVID that I don't think we will know for a while. And that's outside of the health impact, the financial impact, crime, abuse that's happened to people. So one of the things definitely that we've been looking at when it comes to health, you know, and this was alluded to earlier, but the absence of preventative and primary care on these populations. And when you think about the mental health population, the homeless, especially the homeless mental health population, those who have schizophrenia, psychosis, you know, where they usually access the emergency room and then they're sent to the state mental health centers and then they're discharged. You know, a lot of their care was actually put aside. So those are some of the shifting priorities, I think, from COVID back to the things that we were neglected, but also were abused during this time that we weren't aware of. I think they're raising their heads now. We're gonna have to see how we deal with them. So we are taking a closer look at how to get the communities back into screenings, of course, and primary care. And when I say screenings, not just for cancer, blood pressure, and diabetes, but also mental health, and, you know, to hear the stories, you know, what happened to you during COVID, what didn't happen, you know, how you doing? Because a lot of people are holding stories and that affect their health.
Yeah, thank you. Thank you for sharing that. I have two thoughts. So one of which I'm curious from Phil and Lisa, how you might see that as tying into the My Voice project. But two, you know, Tay and I, one of our aspects with this project is we're preparing to do some focus groups related to public health messaging this summer. And, you know, we've already been thinking about, okay, well, the big question isn't quite as much anymore. How do you get information out about COVID? I mean, it still is to an extent, and then that's a big problem and concerning, but all of the other issues you're raising, essentially those like forgotten or invisible issues. How do we ask about that? How do we raise awareness about that? How do we get the word out about help and support for those things? So that may be informative for us as we think about our focus group sessions with communities this summer.
Yeah, and I would add to that, you know, I think that it is something that is definitely emerging, that we are paying attention, we're seeking to pay attention to groups that did not have a very high profile during the first couple of years. The first couple of years really were focused upon those who were being hospitalized, those who were being lost as a result of COVID, because that's what was happening. And that was occupying us, and sort of how do we bend the curve, if you remember those conversations. But I think that now that we are in the third year of this, now we're paying more attention to the long-term effects. We're talking about long COVID. We're talking about the consequences of severe COVID. But even still, there are a group of people whose lives were very changed, and that story was not told. And I think that that's particularly true for people with disabilities, people with mental health, people who are older. And that is what one of the things that we're hoping to do, because it's to capture those stories, because it helps us to tailor the interventions that are needed. Not just the crisis interventions, but the coping interventions, the prevention interventions going forward.
Just to piggyback on that a little bit, one of the things that specifically our lab has always focused on, but certainly prioritized with COVID, is this idea of participation. So especially for our individuals with disabilities, creating a space where they can participate regardless if that space is, a virtual space or an in-person space, so that their stories, like you're saying, can be shared. And so we can identify earlier, if possible, if there's something happening there in a mental health way, or screening for different physical health type issues, just really emphasizing participation and how to access that better.
Yeah, and I think I would just add, just in terms of what we're learning so far from folks we've talked with, in My Story, and also through the Senior Companion Program we've been working with, that like there is a real story about the losses that people have experienced that is not really being told as except in these ways that it's like, well, a lot of people died. But in communities that we have been working with, the amount of loss of friends, family member, community members, has been rather extreme in some cases. And people really, their experience of that and not really being able to, move through that grief in the same way that they might have because of all of the isolation, because of the lockdowns, because of all of the restrictions. That is a story that is starting to kind of emerge. And I think that we have to think about, it's not just about interventions, right? But it's also about like thinking, I think somebody said about prevention. It's like, what do we need to know about this so that we can be sure, that people have access to the supports that they need, if we ever find ourselves in a space like this again, which I certainly hope never happens. But I think there's a lot of stories that just haven't been told. And I'm very anxious, I guess, not in a way to just learn about this, but to be able to find ways for people to capture those stories and share them with others, because I think that in and of itself can create an intervention, right? There's still a lot of people feeling isolated and feeling like people didn't go through this the way I did. And, we know that unfortunately that's not true. And what that means is that, there is an opportunity to make connections for people in that way as well. And I think that's going to be really important going forward.
If I could say one more thing, I think, Lisa, you said, if it happens again, and it will happen again, of course, may not be COVID, but it'd be some pandemic or disaster, especially when it comes to these communities that strike them in similar ways. And I think the stories from before with the previous flu pandemics, disasters across the United States, these are the same communities that have the highest impact. I think one of the things when you say, what are the priorities, we think about short-term and even long-term health of the communities as related to COVID-19, but we also need to think about pre-planning for the next disaster, and what do we put in place? And we've kind of studied this a little and even wrote a little about it, but we need cultural sensitive pandemic planning for these communities that can be put in place next event. It can't be general planning for all communities. We saw that with the logistics around the flu vaccination and the testing. What communities got the vaccines first, which ones got it last. That was general planning, public health planning, well intended, but it does not account for the cultural differences of these populations. So one of the things we really, and it's going to need to have funds to go toward that, but we really need to start the planning and need funding and resources to do this planning for individual communities in conjunction, of course, with these communities.
Absolutely, Dominic. And I think that goes back to what we talked about a little bit earlier, which is that idea of all of us centering the voices, the participation at every step of the way of people with lived experience, the people who we're talking about outcomes for, being the most critical participants in the work that we're doing. Well, thank you. We've got one more set of questions, and I do hope this will help us think perhaps about some of the strengths that emerged, things that went well or are positives that we can then leverage to address some of these issues that are coming up. So our big question here is, what were the lessons learned during COVID-19 for our communities, both aging, including mental health needs and disabilities, as well as things we're talking about here, especially cultural responsiveness. So what do you think we potentially got right across our fields or strengths in the community's response to the pandemic? Don't all speak at once.
So this is Clarissa with the Florida Primary Care Association, also part of CERSN. And we are just starting to make the curve down here in Florida, knock on wood, that we don't have to turn back around again. But we just had our Chief Dental Officer monthly clinical roundtable yesterday. And we heard from Dr. Deborah George, that has been at Jesse Trice as the Vice President Dental Director for many, many years. And she gave a presentation called Lasting Lessons from Pandemic Responses in Safety Net Dentistry. And the very last one I just wanted to share with you because it gelled so nicely with this. Explain how transitions in primary care, dental, and behavioral health caused by the pandemic galvanized opportunities to pursue health equity. And we went through several different scenarios that allowed us to enhance what has always been important to our mission, vision, and values, but to rise to this new challenge and really galvanize that for the future.
I will say, I can at least again speak for us. I think we took a more community engaged approach to our research throughout the pandemic. So we really, we've always been focused on equity and, making sure that we instill that in anything that we do. But we really focused more on really hearing from and making sure to facilitate conversations with our community partners and with the community at large. So with all of our projects, we did some type of focus group or listening session or a survey, or really to garner the experiences of the people that we're actually doing the research about. One thing that was always identified is that it's wonderful when people come into our communities and we, researchers do the research and gather all the information, but what happens next? They never, not never, but it's very rare that they hear the results or they know what their next steps can be to help facilitate more change. So what we did well, we engaged in the community. We continue to do that. What we can still continue to do well is continue to engage in the community. So I think that's very important as we go forward, what we should focus on and continue to do.
Thank you so much, Mitchell. Speaking from education and specifically special education, I think more than ever, we realize the importance of family-school partnerships when it comes to child development and education. So especially students with more significant support needs, and virtual learning was a real challenge, and parents and families and caretakers are juggling full-time jobs while also trying to be a full-time educator for a student for whom virtual learning was particularly challenging, and it was challenging for everyone. But so that idea of being partners, providing more training and supports for families, as well as just kind of recognizing those socio-contextual circles of support that we're all within and operate within and are dependent upon.
Yeah, Katie, your comment also makes me think to Dominic's point about, screening and prevention and sort of the significant role that teachers and schools play in recognizing and reporting child abuse, and how we saw that play out in a significant drop in numbers of reported cases. Even though we knew that it wasn't the case that abuse was not happening as the pandemic took hold. But just like the important role that schools can play as a community partner for a lot of these sort of safety nets in terms of screening for violence, or even, the access to food. When we talked about food security, school-based food programs and sort of the connection there. We don't usually think of education as a primary care service, but there are opportunities to really nurture connections to foster long-time well-being for younger kids too.
I think on a little bit of a piggyback there, I think another thing that we may have gotten right for a small second was this idea to kind of check in and ask some more questions. So oftentimes we're so focused and narrow-minded. So whether it's research or the school setting or wherever we were, just to really be like, are you okay today? Or notice that there's more going on than just that. And then the other thing that we may have gotten right is just this ability to act a little quicker. So whether it's our research or, our check-ins or something like that, I think we were just more aware that we could get things done a little bit quicker than we might have thought in the past.
I guess I would add, it's for just a thought that it really is something I've been running into a lot over the last couple of months, is that taking off our masks, deciding that we could go outside, even deciding that we would get vaccinated and boosted, did not mean that COVID was over. And that reflected both, there was still cases of people becoming infected, but it was also about that people were still dealing with the consequences of what happened over the last couple of years. And if I have a concern, and actually sort of my own students have expressed that to me, that they have talked to me about that they feel that professors decided COVID was over because we started doing in-person classes again and went back to all of the old expectations for students. And they were still dealing with the consequences of what had happened over the last couple of years. And they were right. There were still consequences that are still playing out. So the student population, it's a small microcosm. Their lives are in many ways different from others. But it caused me to think about, well, what does that mean for other groups as well? And in particular, in terms of what we've been talking about, the groups that were a little bit more hidden during the course of COVID, or aspects of their lives that were a little bit more hidden during the course of COVID. What are the consequences that we're not thinking about? And yet there's been an awakening of awareness about some of these issues. And there's been an awakening of collaborations to do something different. And can we continue with those collaborations to really address the residual effects of this pandemic?
Thank you, Phil. Any final thoughts from people that you want to share, or maybe some applications of what we discussed today that you might take back and apply to your work?
I want to respond to something Phil said. And first, I want to say something positive. I do think over time we did a much better job of even the logistics piece. And I look at Georgia, making sure that all communities had the testing and vaccines and also access to information. Something what Phil said as far as like continue the response. One of the things I think we do have to do better, especially from the federal agencies. A lot of this work, as we know, is tied to funding because there is an epidemic or pandemic, and that funding will go away. And once that funding goes away, how do we, even in the academic environment, continue to pay attention to these issues? The other thing is, and one thing we looked at, the masking and stay-at-home orders, we looked across states and really found out that the states who were more conservative when it came to that, actually was a higher rate in certain communities of infection rates and also deaths. Of course, this is a preliminary study, but it came down to the messaging. And we know this time the messaging, political messaging, and in some cases, even from the health agencies, was mixed. And we heard that from communities that, we're saying that communities don't understand and they need culturally sensitive messaging, but hey, the messaging, somebody in DC, Washington, somebody I just saw on TV said, don't take the vaccine. My governor saying, don't mask, stuff like that. So I really do think on the solution side this time, how do we, the advocates for the community, academics, centers, et cetera, before federal funding comes about for something like this, how do we get to communities and work with community leaders to get the message ahead of the messaging that's coming out, whether it's from politicians, seems to have a political focus. Because that message, unfortunately, I can't say we want to block the public message, but that message with COVID was a confusing message with a lot of the communities, and still is. So I think one of the things we are going to have to see, we're challenged with, is, how do we get ahead of that, without federal funding, and continue that conversation and, get ahead of these pandemics or these disasters.
Thank you so much. I think that was a great way to wrap, Dominic. And before I turn it over to Tay to wrap us up, I just want to note that in the chat, so we've got about 8 minutes left here, but just a reminder to navigate back to the main website agenda after we wrap here for the closing keynote and remarks, and that link is there. So I'll turn it over to Tay to just share our contact information and wrap us up.
Yeah, thank you. I don't have too much more to add. I think that sort of conclusion about making sure that we think ahead. We know that another round will come. We have, climate crises will drive public health emergencies. So how do we make sure that we are reflective enough that we are in a position to respond before the after the fact funding comes through? I think that being able to position ourselves to be proactive instead of reactive is one of the biggest lessons that I hope that everybody sort of carries forward from the pandemic. We thank you all, especially folks who participated in our discussion today. It was wonderful hearing from you. If you have any questions, follow-up comments, you'd like to share your work with us further, please feel free to reach out to us. The General Institute on Disabilities contact information is listed on the slide here, as well as my contact information, but I am happy to connect you with other folks on the call today, other folks involved in our collaborative. So please do feel free to reach out. And thank you again for your attention and participation today.
Thanks, Tay. Thank you to everyone.
Thanks, everyone.